Sorry, what time do you want me to finish again?
Quarter two.
Quarter, yeah.
Yeah.
Everyone, thanks for joining tonight for what promises to be a fantastic webinar titled, as you can see on screen, A Pain in the Neck or Something More, Recognising Neurological and Vascular Causes of Neck and Arm Pain. And I think it's fair to say that for many of us, it's quite a challenging area of clinical practice and one that can create uncertainty even for experienced clinicians. Now, I won't steal his thunder too much and I'll let him introduce himself properly, but we're incredibly fortunate to have Roger Kerry speaking with us tonight. Roger is an internationally recognised for his work in the field, and as many of you will know, he was editor of the recent book, The Head and Neck Theory and Practice, and is also programme lead for the BSc Physiotherapy programme at the University of Nottingham. So we're really hearing tonight from someone at the forefront of this area of practice. And just a little bit of housekeeping before we start. As you know, this is a free event and tonight's session will be recorded. We'll be uploading the recording to the NEMS YouTube channel and the link will be sent after the webinar along with your CPD certificate. Now, I'm sure a few people have probably got the jitters and 1 eye of the clock with it being England tonight. So just to kind of calm the nerves, we're anticipating the kind of chat to last kind of 45 minutes to an hour with maybe a short Q&A afterwards. So we should be kind of wrapped up well in time for you to get the cans in, get the pints in, and get in for the England game. While Roger's answering some questions at the end, we'll put a few slides up. So the first one's a QR code for some feedback, and we'd really appreciate your feedback, just so we know kind of what things have worked for people and what things we might do improve for future events. We'll also put a QR code up for our cadaver event at Newcastle University next week. Still a few tickets available for that, and it ties in really nicely with Roger's content tonight. And then finally, we're going to put up a QR code for our annual conference, which is on Saturday, September the 19th in Durham, a beautiful city if any of you have been before. We've got a fantastic speaker lineup this year across a wide range of kind of physiotherapy topics. And there's only a couple more days to secure the early bird ticket. So if you think of going, try and get your tickets in the next couple of days with that discounted rate. So without further delay, I'll stop there and I'll hand you over to the man, the myth, the legend, Roger Kerry.
Thanks, Mark. I'm just going to try and share my screen. So if you could just confirm, can see my PowerPoint.
Yes, we can, Roger.
Great, and you can see and hear me. Okay.
Yeah.
Lovely. Thank you. Thanks, Mark. Thanks for all the NEMS team. Thanks for the invites. It's a great organisation. I was at the conference quite some years ago, and it was a wonderful thing. Yeah, without further ado, then, say any technical problems on the way, you just shout up. Otherwise, I'll just kind of railroad on through this, and yeah, more than happy to discuss things with you after, with some discussion and Q&A. So this is what it's about. So Mark asked if we could do something about differential diagnosis at the start of your consultation with the patient with neck and or arm pain and ruling out the red flags, really. So that's what we're going to do. Okay. Oh yeah, so yeah, a bit of a plug, of course, and I have managed to get a discount for NEMS folks here tonight, and you just need to use that NEMS 20 code if you want to do that. So I'll leave that up for 20 minutes or so while you can get the QR code and things. I'll put this up at the end as well. So yeah, this is a just to acknowledge other people who've contributed to this kind of body of knowledge. Really, obviously Barbara Kenny, she's a Belgian physio, a lot of experience in clinical activity and research with head and neck pain. Generally supported the book with his overall editing, and it was lovely to have forwards by Alison Rushton, who's led on the IFAMP framework, and also Jim Elliott and Dave Walton from across the pond again, major players in the field of head and neck pain. I'll also acknowledge my colleague at Nottingham, Alan Taylor, who over the years we've done a lot of work with. So this is just me, so representing lots of people, really. So what are we going to do? We're going to have a look at this background and the current state of head and neck pain generally in terms of the epidemiology and thinking about how common or rare stuff is, and then obviously go to the big stuff, ruling out the serious stuff. But also I want to frame this not just in the serious pathology. So I'll give all the answers away now in case you want to leave early to get ready for the football. The answers are the serious stuff is really rare. I think we, over the decades, have got disproportionately anxious about some presentations for people with head, neck pain, arm pain, and most likely even with some kind of strange symptoms, that is unlikely to be serious pathology as a cause of that. Even though we're going to spend the next kind of 40 minutes or so focusing on the serious stuff, I really do want to make the effort to frame this and bracket it in the not serious stuff, the musculoskeletal stuff, and kind of dilate some worries hopefully by the end of this. I think actually the majority of people you're going to see over your careers are going to be benign musculoskeletal conditions that are highly treatable and rehabable. And the big point I'm going to make there at the end again is I think we've held off with optimal management and rehabilitation of people with head neck pain because of that kind of anxiety about the neck somehow being a bit different to any other area of the body, and it's a bit more complicated and it's more serious. It's not. It's just there are some slightly different presentations, and actually ruling out serious pathology is just as easy as it is in any other part of the body. And then so the what next thing is about where we're going with kind of management of the people that we see with day to day, and then some questions and answers. So basically, neck pain generally, we know it's a highly burdensome condition. The latest global burden of disease data shows it's right up there at the top of the tables with its impact on health costs and health morbidity, affecting disability just in years. And the big thing there is, for various reasons, there's a very kind of confident prediction that the incidence and prevalence of people with head and neck pain and neck and arm pain is going to grow significantly. And there's kind of some interesting thoughts about that. But we get a picture there. These are the people you say, oh, they're females more than males in that kind of mid-age range, and impact on our quality of life and absenteeism. So it's a highly costly, highly burdensome health condition. That is what we know. So we do need to think about how many of those millions of people get serious pathology. And as I say, Not many. We'll look at some specific data, but getting detailed data on rare stuff is by definition hard because it's rare. But we know that most of the pathologies that are serious are rare. But so we'll look at. I'm grouping them like this, kind of. So the MSK stuff's at the bottom there. Serious pathologies in terms of non-neurovascular, i.e. cancers, infections and stuff, but then vascular pathologies of the head and neck and neurological pathologies, and kind of categorize them like that, which kind of makes sense a bit in terms of both their prevalence and their presentation. So that's what we're going to do. And I'm going to talk interchangeably about neck pain, head and neck pain, neck and arm pain, and try and include that whole kind of thing. So quite ambitious because we're covering a lot of ground in a short space of time, but hang in there. And I'm sure we'll be all right. Make notes and ask some questions after. So if we are thinking about serious pathology and our special questions from a broad headline point of view, it's the same question and the same things to look out for as we would with any other area of the body in terms of risk factors and presentations for cancer. Although I'm going to focus on some specific types of cancer, you're more likely to see people with head and neck pain. Infection, systemic inflammatory disease, spinal cord injury, and fracture are they're the most common serious pathologies that we're likely to come across. So primary and secondary cancers can affect the head and neck. So of course, all of these are capable of producing pain, which is some part of their pathology can look a bit like musculoskeletal pain, and so that's why we're talking about it. With fracture, of course, we've got a highly sensitive, not very specific clinical prediction rule with the Canadian C-spine rule. So we've got a way of judging whether somebody might need an X-ray or not. Or not is the case. We're good at ruling that out. And so despite what I've just said about classifying neuro and vascular things separately, I have thrown this in one here because kind of literature clumps stroke risk in with serious pathology, but I'm going to tease that out and focus on it specifically as a separate entity. But again, just to highlight that there is a framework. It's not a clinical prediction rule. It's not a guideline. It's a framework for best practice about how to best mediate and recognize people with essentially the early signs of stroke, and the early signs of stroke from particular parts of the body, i.e. the carotid and the vertebral vessels, have the potential to present with headache and neck pain. So we need to ask specific things about that, but I am going to go into that in quite some detail. So that's what we're thinking about. Now, I will, now that you've all ordered the book with your lovely discount, you could go straight to chapter 13 because Chris Mercer and team have written an incredible chapter, which is really, really informative about screening for serious neck and head pathologies. And I've just kind of summed up some of the headlines from what we know from the data about the serious pathology, i.e. cancers, infections. So these are the kind of things to look for. We don't have to remember all these if you want to get kind of, clinically used to some of this stuff. These are the most common types of primary tumours found in the head and the neck. And then we've got secondary metastases. So the primaries for secondaries in the neck are usually from the lung, liver, breast, and prostate. There isn't a breast prostate. So we're looking for typical histories of primaries there with the Mets. But the primary tumours that start their life in the neck and the head will present with localized pain. And we ask about, again, the same kind of cancer patterns and everything else. How did this start? Was it benign? What's the progression like? And there's commonly within these groups is that report of my neck hurts, but it doesn't feel quite right. It's not like I've twisted my neck before. This feels a bit different. So we're listening out for that unusual, the word unusual coming through in the history taken. Same with the Mets, pain, again, typically worse in lying. commonly associated with radiculopathies and weakness of the upper limb. But this is depending on the site of the mess. Obviously, this could affect lower limb as well. And again, unusual symptoms. And there is no specific diagnostic test for any of this with known diagnostic utility. But we are, again, translating what we know from other areas and doing things like observing and palpating for any unusual or asymmetrical or painful masses or swellings. We can use something specific like the Met sign, spinal tenderness, but also the thing there is a full neuro examination. What we mean by that is upper limb and lower limb and cranial nerve examination. It's any little indication of anything being serious. The cranial nerve examination is particularly important. We can think about specific things like metastatic spinal cord compression. So again, secondary METs, pressing on the spinal cord, we're just looking for signs of spinal cord compression there. So full neuro will help there. And then a series myelina, again, spinal cord compression, often associated with hair malformation. That typical kind of cape-like either numbness or pins and needles is something to look out for there. A lot of stiffness around the shoulder region and the neck, atypical headaches, balance dysfunction, bowel and bladder dysfunction, and again, unusual feelings. Again, a full neuro examination. And then right at the bottom there, about serious pathologies. Well, it's not really a serious pathology, but it can cause complications for the head and neck and shoulder region. Systemic inflammatory arthropathies, particularly rheumatoid arthritis, and just going back and thinking about the formation of the odontoid peg and the laxity of the upper cervical ligaments in there as well. So, that's not going to kill anybody, but it might create some contraindications for what we do in physical examination. But a lot of strength testing around the neck will help understand the kind of patency of the craniocervical region. And again, a full neuro in case there's any spinal cord compression. So that's a very brief kind of headline overview of the serious stuff, but I would point you towards Chris's chapter there. And again, just to highlight two things that shine out to me there. History, listen to the word unusual, or listen for the word unusual. Examination, full neuro examination. If you do those two things, you've covered your bases as best as possible. Our job isn't to make a diagnosis of a particular type of cancer. Our job is just to see, is there something weird happening here, and who's the best person to send them to? So I'm going to just kind of move on and give you a bit of a case study here. This is David. He's 55-year-old male builder. 3 months of neck pain, anterolateral, and headache at the side of his head. Thinks it started after a busy period of work. Is obviously carpenter or joiner there. Says pain feels unusual. So again, immediately we're thinking, we're not ignoring those words. They're not nuanced kind of phrasings from a patient. The word unusual is a really strong indicator of potential red flag. Thinks he's pulled a muscle on the side of his neck, so goes to the GP, gets referred to physio. General health reports high blood pressure, has been told by physio that he may have a torn sternocleidomastoid. Of course, sternocleidomastoid can tear very easily. And he has stiff intervertebral segments and possible disc protrusion. Gosh. He's been doing repeated gravity-assisted neck extension exercises. I didn't want to say any names like Mackenzie, so I've left those out, but basically Mackenzie extension exercises, lowering his head into extension off the end of the head. And but now the symptoms are significantly worsening, but he's been told to keep going with the exercises. Now, I want you just to keep that picture in your mind as we go through this next little chapter. And hopefully I've repeated this slide later on, otherwise I'll have to remember to kind of give you the answer of what this is. But the point here is, regardless of the detail of what it is, whether it's cancer, whether it's something to do with stroke, or whether it's something to do with a peripheral neurological problem, there are some red flag indicators there, which is the kind of onset, the site of the pain, the onset, the unusual feeling, a background of high blood pressure, and the fact that it's not getting better anymore. So just think about those things. So I'm going to talk now about stroke risk, or it might not be just stroke, but if we talk about vascular or arterial flow problems of blood going from the heart to the head, but most commonly that might result in a stroke, or stroke-like pathologies. And again, the kind of the link to physiotherapy here is that phenomena of having restricted blood flow going into the brain can present not with neurological symptoms and signs, but with musculoskeletal, seemingly musculoskeletal signs. So this IFOMP framework was first developed in 2012. It's recently been updated. And again, just to acknowledge the authors on here who need some serious acknowledgement because they contributed so much. This is an international cross-disciplinary framework. So we've got Alison Rushton, who's a physio, Lisa Colesso, who's a physio, Tim Flynn, who's a physio from the States, Wayne Hing is a physio from New Zealand, myself, Sydney Rubenstein, who's a chiropractor from the Netherlands, and Steve Bogle, who's an osteopath from London. And we also had neurological consultants review the document as well. So it's a fair, but again, if you're not familiar with this, you know, I think you'll get copies of these slides anyway, or if you can Google it. But there's information, and it's a lengthy document, but we've tried to summarize a bit with infographics. So, but I'm going to go through this now. So this new framework, so this is to help us as physios understand whether somebody walking into our clinic with neck pain, headache, plus or minus shoulder, arm pain, is walking in to see us with the early signs of stroke or not. That's what this is about. The old kind of narrative about manual therapy causing stroke is getting more and more redundant and less supported by data. Those cases where, say, a high velocity thrust has resulted in somebody having a stroke are most likely not caused by the intervention. Certainly the pathological process is probably exacerbated by it, but the cause of the stroke was probably in situ before they even got to the therapist. So it's not so much a matter of a manual therapy technique causing stroke in some random way. It is the therapist not recognizing the patient was walking in with early signs of strokes, going ahead with what they kind of would normally do anyway, and they're the consequences. That's our interpretation based on a review of every single case study that's been reported, and every study that's looked at a case series of these events or not. So we're shifting that narrative from manual therapy is dangerous to I need to be better at clinical reasoning to identify early signs of stroke. So the framework includes a number of infographics, which the aim is to help the clarity of the document, even though they all are a bit messy as well. But I'm going to talk you through them. So we take a history, and there's key things to look for on the history. A physical examination, there's key things to do on the physical examination. And then ultimately we can talk about the risks and benefits of interventions. It's not just manual therapy, it's exercise as well. You know, the carotid artery and the vertebral artery don't care at all whether it's a therapist moving the neck or if it's some muscles moving the neck. So whether you're doing passive movement, active movement, it doesn't matter in terms of stroke risk. It's the movement that matters. So we've used that term there, orthopedic manipulative therapy, but it is a bit dated and we need to think of it wider. There's tools there about clinical reasoning and shared decision making, And there's, for anybody involved in education, there's some guidance on how we should best do this. So the first thing to think about, I don't know what, obviously there's a lot of you here and you've all had different levels of training, and that level of training would depend on when you trained as well. So when I trained, and for several decades, several years after, we were very much taught about this kind of stuff in terms of this thing, this thing called vertebro-basilar insufficiency, and there's this thing called manipulation, and you've got to be careful about those two things. As I've said, that's not the kind of story anymore. If you were taught something like this, patient comes in, you wonder if they've got VBI. VBI is not a thing. It's something that was made up in the 1950s and 60s to make physio sound a bit clever. It's not a diagnosis. It's not a condition. It's not pathology. It's a unicorn. Ask about the 5 Ds and 3 Ns. That's nonsense. There's no diagnostic value in doing that. And then do a functional positional test of the head, and basically the theory would be, if you suspect something serious, then turn somebody's head, and if they have a stroke, it was serious, and if they don't, it wasn't. Again, that is nonsense. That has got no diagnostic utility to support its clinical use. So we need to move away from that and just think a bit more fundamental and basic, actually. Like we do in every other region, we think about cauda-equina syndrome for low back pain. We think about different serious pathologies in the hip and the knee and blah, blah, blah. This is just the same. So when we talk about vascular pathologies, or there's the acronym there, CAD, cervical arterial dysfunction. That's a bit dated now. I tend to talk about vascular pathologies. Basically, all we're saying is what kind of pathologies affect the arterial system that can restrict blood flow to the head, that can potentially and have been reported to result in pain of the neck and the head that can mimic musculoskeletal pain. And that is this list here. So we've got pathologies affecting the carotid artery and the vertebral artery, and different types of pathologies ranging from dissections, which is a small tear on the inner layer of the vessel, to systemic diseases or localized diseases like atherosclerosis. We don't have to remember that again, because the presentation for people with any of those things is quite similar in terms of the pain is unusual, it's not progressing in the way we want. On a day-to-day basis, it does look a bit mechanical, but over time it's worsening, and there is a background of risk factors as well. So a bit of a formatting issue here. I put that term VBI up there in a small red box just to indicate that we use that term, but it means something or nothing. And in the prevalence of other things, we can see the more important stuff. So certainly vertebro-basilar dissection is a bit more common. Vertebral artery atherosclerosis is more common than that. Then we have kind of non-pathological things like compression of the vessels from the mastoid process or the sternocleidomastoid or something. Got hyperplasia, things, aneurysm stuff. Then we move on to the internal carotid artery, which is a more common pathologies affecting that vessel. Dissection, thrombosis, stenosis, aneurysm. Subarachnoid hemorrhage is conceptually different in terms of its medical management, but it can still present in similar ways that we're talking about. Extracranial presentations like temporal arteritis, cerebral vessel vasoconstriction, but the most common thing you're likely to see that may present as head pain is internal carotid artery atherosclerotic lesion. So there's been no dissection, there's been no spectacular rugby accident and a big trauma. It's something that's grown over time, affecting people towards, mid-40s onwards. Looks quite dull and boring and looks a bit musculoskeletal, but the cause is there, and the problem there is that there could be embolization from the localized plaquing. So how does this all translate to the shop floor? So let's go through some history taking. The first thing is to think about the pain and the site and the nature of the pain. Again, with the caveat that we're kind of working best as we can with small scraps of data from the shop floor and the research floor here, because again, this is rare stuff and you don't get generalizable patterns. You do get some commonalities, and that's what I'm going to pick up on, but there are no set rules. So in a minute, I'm going to say vertebral artery causes pain here. Commonly it does, but it could be different presentations. But the key thing is to understand that neck and head pain is a common early manifestation of cervical arterial dysfunction or vascular pathologies. Uh, I don't mean common in terms of it's like 50% of all people with neck pain. What I mean is, um, if you have stroke, which is of cervical origin, i.e., carotid or vertebral origin, as opposed to coronary artery origin, around you've got around 80% chance of having neck or head pain as an early sign of that stroke. And that's where we come in. So again, typically, not typically, the vertebral basilar system will present with pain, unilateral pain on the back of the head up to the occipital region of the thing. Now, the important thing here, this pain mechanism isn't ischemic pain. This is pain, nociceptive, mechanical pain from the free nerve endings in the blood vessels that have been compromised either through disease or compression. Hence, it can be quite mechanical. So if I've got a pathologized vertebral artery here, this is before the brain gets involved at all. There's as yet no reduction in blood flow to the brain. But I've got this soft tissue structure here that when I stretch it, when I turn into that side, it produces pain. So it's nociceptive mechanical pain, but the nociceptive source is the blood vessel. This is the typical pain pattern for the vertebral artery. The internal carotid artery, which is more temporal parietal region of the head, and pain, unilateral pain coming around the side of under the ear and towards the jaw as well. Same mechanism. If we've got pathologized carotid vessel, it's got the capacity to cause nociceptive pain. And this is the best stage to identify a patient before we get neurological signs and symptoms through brain ischemia, because the medical and surgical management is much better here. If we can, but it's really difficult because it's just pain. Can you see how there's not got to be any 5Ds or 3Ns? They are, if they even did exist, they would come much later on. Again, one of these clear, not clear infographics. This is just kind of the one useful way, clinically useful way of thinking about this is thinking about dissection pathologies versus non-dissection pathologies. But having said that, there's a lot of similarity in the way people present. The only difference is dissection is the province of the younger person and usually associated with some kind of trauma, and non-dissecting events like which are atherosclerotic based are older people and not necessarily related to trauma. The other key thing there is that a background of cardiovascular risk factors is much more important to establish in the non-dissecting events, whereas other than kind of whether you're a current or past smoker or got high blood pressure, they're not so significant risk factors with the younger person, although we do ask about those, of course. We obviously, if there are a lot there, it makes a difference. And again, the signs and symptoms are a mix of head and neck pain, various types of weakness. This is where our 5Ds and 3Ns would sit if they even existed. But you can see there are some of those things. We've got dizziness there and things like that. But dizziness isn't actually that common in these vascular problems. Disequilibrium is where there's a cerebellum phenomenon where you feel like you fall into one side. But spinning sensation would normally be a discrete vestibular pathology, not a vascular pathology. These are just kind of timelines that kind of, in my mind, help a bit. And the key point here is that we think about the non-ischemic stage or the pre-ischemic stage, and then the ischemic stage when there is ischemia to the brain. But it's in the non-ischemic or pre-ischemic stage that we really want to identify people, because by the time it gets to the ischemic stage, that's when people are stroking out of it. Now, the good news is we can, with measuring blood pressure and looking at cranial nerves, we can try and pick people up early, but you're not going to do it with an old school 5Ds 3Ns movement test. It's the same with the internal carotid artery. We've got the non-ischemic stage. These are much easier to identify early on because of the anatomy of the carotid artery in the transcranial area. It runs alongside parasympathetic nerve to the eye, so we get Horn syndrome, and it runs along the extracranial extensions of the lower end cranial nerves. So we get cranial nerve 8, 9, 10, 11, 12 buggered up as well. And that's good because it's in the pre-ischemic stage, because it's just a mechanical space occupied lesion. Very similar to a Pancoast tumor presentation. And you might not even know whether this is a Pancoast tumor or a carotid aneurysm. It doesn't matter as long as you refer them to get investigated. Then, of course, the ischemic end is normally a middle cerebral artery stroke. So it's, again, too little, too late. Again, just to highlight that point, this is from recent data from people like Rick Cranenberg in the Netherlands and Lucy Thomas at Queensland. Again, just to hammer on that point about dissection events are normally the province of the younger people. Risk factor also migraine. The good thing about that is a patient will tell you if their pain feels like their usual migraine or not. And if it doesn't, that's a red flag. And then it's establishing the risk factors, cardiovascular risk factors for the other people. And those cardiovascular risk factors are the usual things like smoking. So we can classify trauma as a cardiovascular risk factor in so much it can injure the inside of a blood vessel. Whether there's a history of cardiovascular disease in the family or themselves, repeated upper respiratory tract infection, hypertension is the biggest one. History of migraine, diabetes, anticoagulation therapy, but also an absence of an alternative hypothesis. If you can explain this presentation better with an alternative hypothesis like sensorimotor dysfunction or something, it's probably that, because it's more common. Physical examination. There's an infographic there for do it. This is a simplified way. The IFOMP document explicitly states not to do a VBI test, a functional positional test. We know it's got data behind it, and we know it's got poor diagnostic utility. But blood pressure, pulse palpation of the carotid artery, cranial nerve examination, and lots of coordination, proprioception, and gait stuff will give you a broad picture of whether something's wrong here or not. Just a couple of provocative slides again about the VBI test. Nathan Hutton's systematic reviews still not been challenged by any contradictory data, so we still don't recommend it for clinical practice. And this down here, this is I started going on about this, what's that, 24 years ago? And people, I hear in clinical practice, people are still asking about the 5Ds and 3Ns and doing a VBI test, and that should have been stopped 20 odd years ago. Incredible. Cranial nerve examination, just a few pointers. Alan Taylor has done some really lovely, during COVID, he did these really lovely videos to point us on our way. And there's a link down there to a really nice paper by a bunch of medics that was produced during COVID about how to do a tele-assessment neuro examination, cranial, upper limb, lower limb. Really good resources. Have a look at those. If we do a good job and exclude everybody we think are those kind of presenting as stroke, the rest aren't. So musculoskeletal, the data for risk versus benefits of any intervention for people with head and neck pain, the benefits will always outweigh the extraordinary low risk of adverse events. This is just a very basic classification system that here, class 1 and 2 musculoskeletal people, it's just saying what I've said already, really. Treat these people. refer these people. They've got the early ischemic, late ischemic stuff. It's just a way of forcing that decision. Briefly now on to neurological pathology. This is more common territory for you. We have got clinical prediction rules. We've got ways of identifying or ruling out people with myelopathy. Just think about when there's bilateral hand dysesthesia. So again, can present with neck pain, bilateral distal symptoms in the upper limb, and there is a lovely scoping review recently published by Sharma et al. That scopes all the data and systematic reviews on this, and we have got some clues of what to do there. So we've got some tests with great sensitivity and specificity. So to rule in or rule out DCM. Just a point on there, we see lots of people referred on with a positive Hoffman sign. That is not a good sign to refer people on. All it will do is irritate the neurological consultant and give physio an even worse name that it already has in those circles. So don't refer somebody in with a positive Hoffman sign, rather take a more holistic view and think about those kind of things as well. Cervical radiculopathy. So myelopathy, central compression of the spinal cord, radiculopathy, nerve root compression. So unilateral symptoms with arm pain worse than neck pain, plus or minus dysesthesia in the lower limb. Lovely infographic from Chris Walsall there that just sums everything up, and everything's about the same, but basically stating the profile and the presentation, and obviously this isn't serious pathology because we can treat cervical radiculopathy, and there's been some lovely recent work. So the original work was from Weiner with the cluster to as a clinical prediction rule, which was at that time good, and that's back in 2003. This is my kind of interpretation of the journey of cervical radiculopathy. We go from Weiner to Eric Toombs's systematic review, which modifies that CPR a bit, to Grondin's latest, and Chad Cook and Toby All are on there as well, of course. So this is all you need to remember. There are 3 tests that will rule in or rule out cervical radiculopathy: a positive Sperlins, a relieving shoulder abduction test, and a positive upper limb, or a number of upper limb tension tests being positive, and they will with great confidence rule in or rule out somebody with radiculopathy. And all that will do is direct your management a little bit. So some really nice stuff there. Just want to finish off talking about headaches. By the way, David, our case study, was a carotid artery atherosclerotic based dissection. So it was a mix of everything. And the Mackenzie extension exercises were the absolute worst thing he could be doing, because that is mechanically stressing an already dissected carotid artery. So he went on to have surgery, and he was presenting with a drooping eyelid and cranial nerve dysfunctions that the physio never even bothered to look at anyway. Headaches, very common. We talk about tension type headaches, migraines, and cervicogenic headaches. Most relevant is cervicogenic headaches for us, which account for up to 20% of all chronic headaches. Although more recent thought and work, some of it is dubious data, some of it's good, but we're starting to question the mechanisms of tension type headache and migraine, and there is some early work looking at the stuff we do for cervicogenic headache could also help for tension type and migraine as well. Still don't fully understand the mechanisms there. But just in terms of headache classification, of course, we talk about primary and secondary. We're interested in secondary headaches, cervicogenic. If you're not familiar with the latest headache classification system, it's available. There's links here, but there are hundreds of types of headaches. But cervicogenic headache fits in at 11.9 there among the 348 types of headache or whatever. So it's cervicogenic headache is a recognized diagnostic headache. We can measure the impact of headaches with outcome measures. And migraine specifically, we can look at outcome measures. Just a note on headache red flags. If you remember just one thing from the whole of the talk, because this actually applies to everything, the golden rule at the bottom there, if this is the first or worst episode of headache or neck pain, that is danger. And just even on that alone, do it. So if somebody's never had a headache before, that's a red flag. If it's the worst episode of headache people have had, that's a red flag. And the red flags for headache, again, we've covered these already, but just to sum them up again: subarachnoid hemorrhage, carotid dissection, vertebral dissection, brain tumor infection, GCA, and then other stuff that just doesn't respond to treatment. But first or worse. NHS has got some fairly good advice on when to see a GP or 111 or 999 in terms of headaches, but that ties in with what we've just said on the previous slide, but that's a nice resource there for you as well. And again, just a bit of pattern recognition between migraine without aura. Obviously, migraine with aura is very easy to differentiate, but migraine without aura versus, that's just a little picture of how aura looks. But we're interested in migraine without aura. Tension type headache, and cervicogenic. So they're all characteristically different in terms of their frequency and patterns. But look, with cervicogenic headache, you can still get lots of weird stuff going on: nausea, dizziness, photophonia. Same with some neck pain things. You can still get that stuff because that's just the local neurology. It doesn't necessarily mean it's serious. So if we can rule out everything serious with the neck and the head and the arm, and there's no significant neurology, we can think about classifying neck pain as non-traumatic causes, or non-whiplash trauma, or whiplash-related trauma, just because those things all present slightly differently. And with the traumatic, particularly with the traumatic type of head and neck pain, again, you can get a lot of associated sensory-motor dysfunction that can present with dizziness, nausea, double vision, drop attacks, all sorts of things, but they're not serious. They're just part of the local neurology. We know from good quality evidence that these things do not cause neck pain, and therefore any intervention based around tight muscles, stiff joints, trigger points of lesions, imbalances, poor posture are nonsense, and we shouldn't be going down that line at all. And we know the key things are modifiable psychological risk factors and social risk factors, and some biological factors. So we need to focus our management towards those. And again, Lynn's, 11 points for best practice in musculoskeletal pain apply strongly to people with neck pain and head pain as well. So there's a link for that there. But we should be thinking about reassurance and education. Manual therapy does have an adjunct role and can decrease the cost effectiveness and increase the long-term clinical outcomes of this, but you're not targeting stiff joints or anything. You're just providing a safe environment for somebody to re-experience the movement they should have. Lots of proprioceptive muscle control stuff, plyometric stuff, resisted stuff, and functional stuff is where we need to be going down. Even with all this, there is still an increase in prevalence of all this stuff and a predicted further increase. So we still need to think harder about what we're doing for people with neck pain. We still need to be scratching our heads. I think there's a few future directions. Risk, and if we split it into risk and rehabilitation, risk, as long as we kind of tune in with what we've been talking about this evening, that's fine. Rehabilitation, I think there's some future in thinking about people with head and neck pain and arm pain and their dysregulated breathing. And I think, again, revisiting some proprioceptive stuff, and HeadX is a nice little company who's starting to think about that again, is another direction, as well as more focus on strength and conditioning of the craniocervical muscles, which is disappointingly neglected in most rehab. And there are two things there. Risk, it's all very rare. Everybody else, it's all very common. And that's all good stuff. That's another link to the book. And thank you. I'll stop. Football's nearly on.
Thank you very much, Roger. That was fantastic. We have a few questions in the Q&A at the minute, so I just wanted to put a couple of those to you, if that would be all right. Someone's asked if you could maybe just quickly show the slide with the cranial nerve testing links again. I know that was a few slides back.
Yeah, that's fine. So I'm happy to send these slides to. I don't know if you've got a way of getting these, because it's full of hyperlinks and things. So, but here.
That's grand. So maybe if we just leave that on for a few seconds, but we'll try and get it out to people this email. Just to say, we are aware that there was a few people who had sound issues. It didn't seem to be everyone. There's lots of people who didn't seem to be having sound problems, but there did seem to be a minority of people who were having some issues with the sound. So apologies for that. Hopefully when we upload it to the YouTube channel, hopefully that will be resolved. We've got another question, Roger. What is the best course of action if we suspect precursive symptoms of a vascular event? Would we send people to A&E with a letter? Would it be 111, 999?
Yeah, any or all of those things, depending on the stage. So great question, and I'm mindful that I didn't address kind of management of the serious pathology and what we do about that. So thank you so much for asking that question. So it very much depends on the stage they're at. So obviously, if we're in the ischemic stage and somebody's displaying some central neurological symptoms, then it really is 999. Don't move them. 999. Get them. If you're suspecting it's kind of pre-ischemic, somebody's got this weird neck pain, maybe a couple of cranial nerve dysfunctions, it's probably a call to the GP. Or send them to ED. There is no guidance on this, so it's that clinical judgment again. And again, it is like anything else, you know. So somebody's called requiring, if somebody's like full blown, symptoms, you're not going to move them. If somebody's got some vague stuff, keep an eye on this for 48 hours, let me know, or your GP know, that kind of thing. The problem with referring them to ED or even GP a bit on the early side is bounce back, because these are so rare, the GP will either say, oh, I've never heard of this carotid artery thing, whatever, just get back, or so often. But the chances are more than 80% chance that you'll have a elevated blood pressure, significantly elevated blood pressure, and possibly some cranial nerve signs. If you get those numbers down, that really does help with that referral. If you say, you've got this 21-year-old rugby player suspecting something weird, but his resting blood pressure is 210/170, and cranial nerves 6, 7, 8, 9, 10, 11, 12 are all knocked out, then more likely to get them seen. So yeah, it depends on seriousness, but 999 if there's lots of neurology going on.
Thanks for that, Roger. I've got another one. How common is tinnitus as a symptom with neck pain? I have a patient who fell asleep on the sofa and woke up with neck pain and tinnitus. Tinnitus aggravated by side bending movements of the neck. All investigations, ultrasound, MRI negative. ENT consultant not worried.
Yeah. Fantastic question. My answer is more common than we probably think or know. Again, if you've had the head and neck pain in practice, there's a couple of lovely chapters in there by Sarah Mitchells about tinnitus. One about the pathology of it in relation to the neck, and another one about treatment interventions for it. So it's one of those lovely things, I think, where we just started to learn a bit more about it. And as I say, I think it's probably more common than we've ever appreciated, that tinnitus can be just another part of the package of neck dysfunction. And there's some kind of deep kind of neurology to explain that. So you won't find anything on imaging or whatever. But as long as that other seriousness is ruled out as a cause, then it's probably just something to monitor as you kind of do your rehab with their neck.
And we've got another question, Roger, and this is a kind of question that I had myself, actually. Someone said, I qualified 1 year ago and was taught always to ask the 5 Ds and 3 Ns. Why do you think this is still taught at university? And I can vouch for the fact that it definitely is still taught at university.
I don't know what to say. I can make some recommendations about maybe ask for some money back or something like that. I really don't know. It's so we've been doing a lot of survey work with education providers and clinicians, mainly in North America, but some UK stuff as well. So we've had a few recent publications. People like Nathan Hutton and Firas Murad and James Dunning have been doing a lot of work trying to find the answer to this. I mean, part of it is we know there's this classic 17-year gap of getting evidence into practice and stuff, but I think it's more than that. I don't know. It's just completely out of date. It really shouldn't. We've made strong recommendations throughout the years, both in academic publications, in CSP lobbying and advocacy, in international level at IFOMT, local level. I just don't know, Mark. You're the generation to answer this. Sort it out.
And a follow-on question from that, Roger, how do you feel like we should challenge that kind of fixed mindset that we have to ask those 5Ds and 3Ns? Where do you think we stand in terms of a litigation point of view? If someone's been told we need to ask that and then
Right.
get litigation?
This is quite clear. The fact that you've been taught something holds no weight at all in litigation. What matters is how you can reason, rationalize, and justify that. There have been some cases over the last 5 years, and it's as simple as this. If you did this, if you did that kind of package of assessment, 5Ds, 3Ns, and made a clinical decision on that, and so something went dramatically wrong, and you tried to use that as justificate. Well, I did all I could. The answer is simple. That is not evidence based. You got no rationale to support what you did. You should not have made a clinical decision based on the results of that. You are medically negligent if you do that. Do not do those things because you are medically negligent if you do that. The IFOMT framework is the accepted medico-legal level kind of guidance for this kind of stuff. And in that framework, it explicitly says do not do that kind of stuff. So you're on very dodgy grounds.
To that, Roger. Someone's asked a question. What do you think might be the cause of the continuous increase and projected increase in these type of pain? Do you think it's socioeconomic issues, time spent sitting or inactive, or lifestyle factors? What do you put that down to?
Big question that is. Fantastic question. But the trend for neck and head pain is no different to the predictions for all musculoskeletal pain, according to the Global Burden of Disease. So the question kind of sits across everything, really. Why is knee pain going to get worse? Why is back pain going to get worse? I imagine a lot is socio-economic and driven by. I mean, World Health Organization have a bit of a product. People like physiotherapists saying you need to up your game. You say you're the profession that's best in dealing with musculoskeletal things. Is one, it's worsening. Two, it's going to worsen even more. One is the kind, and again, a bit provocative this is, but again, it comes from hype. It comes from World Health Organization and the medical community, people like Muir Gray and stuff. Physio is kind of swimming against the tide. By looking at the management of people at a one-to-one level, you're not going to make a dent in that data. We've got to be looking at population level interventions and messaging for this sort of stuff. And until that happens, we literally are swimming against the tide. And it is always good. MSK stuff is always going to get worse. We need to radically rethink how we do things.
Just a couple more questions we got, Roger. If we're suspecting a vascular cause, maybe a non-urgent or not kind of A&E type presentation, and sending to the GP, should we be proposing what tests we might think that they would do, or what tests do you feel they should refer for?
Yeah, and the feedback we've had from GPs has been very positive about this. But again, because they don't see this all the time, or even ever at all, they really don't know what to do. So again, my apologies for neglecting this side of it. But the gold standard investigation for this stuff is MRA, magnetic resonance arteriography. And the GPs we've done some work with have said they do not at all mind the physio saying, I suspect, I'm not sure, I suspect this is something vascular. I understand the gold test is MRE, blood pressure is high, da 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 da. I understand the gold standard test for this is MRA, because you don't want to be wasting your time with plain film or CT or MRI. So so it's MRA. That's the test.
And someone's asked, I guess a related question: is there a gold standard medical workup for the earlier presentations, and where should this happen?
Uh, what on the vascular side? No, there isn't. I mean, the IFOP document is the closest you get to that, and it's by no means gold standard. So the medical diagnostic workup is the historical stuff as per the IFOP guidelines, so the risk factors kind of stuff. Blood pressure measurement, cranial nerve testing, MRA.
Grand. Final question, I think, Roger. Can repetitive self-neck manipulations by patients harm the arteries or other structures? I've seen a patient who had a habit of clicking his neck daily at least 10 times. And also, I've personally dealt with someone who went on to actually have a stroke, and they thought it could be overly aggressive manipulations with a massage ball on the inside of the neck. I don't know how kind of feasible you feel like those would be.
Yeah, I mean, not unfeasible, not terrific. So what we know is that the mechanical risk is end of repeated or sustained end of rangeness into rotation or extension. So if you just went by that, the kind of answer would be, well, unless they're doing that towards end of range, repeatedly, really end of range stuff, technically it shouldn't be a risk. Same with the massage ball. Having said that, massage ball or pressure with massage, particularly more kind of anterior lateral, can directly, mechanically affect the blood vessels. So, but again, most people got healthy blood vessels. But if you've got any sort of risk factors that predispose you to endothelial dysfunction, intimal dysfunction, then yeah, I think possibly that those things are feasible on some sort of subtle background of predisposition. I mean, why are you doing that to your neck anyway? It's a bigger question.
Right, well, that's great. So thank you very much for your time, Roger. People will have seen we've just been flashing a few QR codes across. Just to re-emphasise that there's 2 days left, so the early bird pricing for the annual conference that's on the screen now ends on Friday. So as I say, people want to secure like a £20 saving on the ticket price, then make sure you book those tickets before Friday. Otherwise, I'd just like to take this opportunity to thank Roger for a fantastic talk. Much appreciate your time, Roger, and I'm sure you've given a lot of people food for thought as well. So much appreciated, Roger. So yeah, thanks again. All right, thanks everyone. Have a good night, and hopefully we'll do the business.